So, welcome once again, Dr. Salika and Dr. Fatima. Uh, Last time we discussed a case of anemia, which is more of iron deficiency. So, today we are gonna discuss this another high yield points for anemia, right, which is related with the hemoglobinopathies, just for your kind knowledge. So, I will going to give you the real tips how you supposed to answer in Oman Viva, right, in the exam. If you are joining first time, you have hardly 10-15 minutes in Oman Viva. They're supposed to ask you 2 to 3 questions, and if you give the perfect answer, you are done. If you are unable to answer well as per their satisfaction, then it's tough time. So we need to be very, very specific in answering. Uh, Wherever you feel that you don't know the answer, straightforward, you can say, I don't know the answer. If you try to, divert the MCQ, they probably divert more than you. So it would be on a different track, right? So just to save the time, you can say that I don't know the answer. So they probably go on the next question. That would be the better practice. Another thing is you have given the clear cut scenarios that you have to listen it and read it properly, and then you have to give the answer. Each and everything or most of the things are given in their scenario. If not, you can ask the questions, right? Like past medical history or some surgical history. If it is relevant, don't waste time asking the irrelevant questions. Try to ask the relevant questions. So I think Dr. Fatima, you were not there in the last class, right? If I'm not wrong.
I'm there, sir.
Sorry,
I was there, sir.
you were there, no? Fair enough, no worries.
Ah, okay.
So yeah, so just go through the revision of that as well. So let's start with the questions. You have a 9 years old girl, weight of 20 kg with past medical history of anemia and blood transfusion and jaundice. She is now evaluated for several hours of moderate to severe pain at 8 out of 10 score in her arms and legs. She has had 4 episodes of similar pain with fever. Parent has history of some abnormal hemoglobin. On examination, blood pressure is stable. Heart rate is 110 per minute. Oxygen saturation at 94%. Now afebrile. Tenderness on the palpation on arms and legs. No deformities or concerns for infections now. Lab shows hemoglobin of 7. MCV is 83. Right. Rest of the things are fine. Hemoglobin electrophoresis was done, which was more than 90% HbS and no HbA. So how you gonna manage this case? So first of all, the question here, first of all, what's the diagnosis, right? What's the diagnosis? So what is the diagnosis? So I'll ask you few questions to Dr. Salika and few to Fatima. So you can start, Dr. Salika. What's the diagnosis of this patient?
uh, Sickle cell anemia, and the
Sick,
patient is
sick,
having acute pain crisis.
Sickle cell anemia and patient has a pain crisis. Okay. So how did you get to know or how did you differentiate between sickle cell trait and sickle cell disease or anemia? How you exactly differentiate with this both the condition sickle cell trait versus sickle cell disease or anemia? Yes.
Um, in sickle cell trait, they are carriers with the AS will be there.
Okay.
But in sickle cell disease, they will be SS. Both the
Okay.
genes are affected,
Okay. Fair
and
enough.
um, then sickle cell trait will be almost like less symptomatic. But in sickle
Mhm.
cell disease, there will be more symptomatic and more crisis.
Okay. Fair enough. Good. Wonderful. What else?
Um,
Uh,
that's all for me for now.
Fair enough. Any things you want to add, Dr. Fatima? Sickle cell
Um,
trait versus sickle cell disease. It's a basic question, isn't it?
Sir, in sickle cell anemia, we have to give prophylactic folic acid and antibiotics, sir. Hello, sir. Sir,
Yes, I
can you
can
hear
hear
me,
you.
sir?
Yes, absolutely. I'm listening all the. We are not in hurry. We will do the things properly. Yeah,
And
tell me what's the
clearly,
difference?
in sickle cell anemia, we have to give folic acid and antibiotic treatment, sir. Prophylactic treatment and vaccination,
Mhm.
pneumococcal and hip vaccination.
We'll come to that point. This is the
Okay.
head-to-head comparison between sickle
Okay.
cell. We'll see each and every point properly, very well. So hemoglobin electrophoresis. So first of all, the best test to diagnose abnormal hemoglobin, right? When you want to diagnose abnormal hemoglobin, the name of the test is a hemoglobin electrophoresis, right? So here hemoglobin electrophoresis can diagnose sickle cell trait, sickle cell disease, right? It can diagnose thalassemia trait, thalassemia minor, thalassemia major. It can diagnose the combination of sickle and thal both, right? Sickle thal, right? It can diagnose another many abnormal hemoglobin like HBH or Punjab, right? So there are a lot of things. So whenever you want to diagnose abnormal hemoglobin, right, in the blood, hemoglobin electrophoresis is the investigation of the choice. They may ask you what test you do the best, right, to diagnose the sickle cell. Your answer should be hemoglobin electrophoresis. How it differentiates sickle cell trait and sickle cell disease? The biggest difference between trait and disease is amount of the sickle. Let me tell you what is the normal. So normal here is first is normal, then sickle trait and this. So here normal, the hemoglobin is supposed to be 95 to 98%, right? HbS is absolutely 0%, 0%. HbA2 is 2 to 3.5 to 5%, and HbF is less than 2%. This is normal. Now see what's the scenario here. So whenever you are answering any questions with the sickle trait or sickle disease, right, the amount of the sickle is the main differentiating point. So here the sickle is 35 to 45%, and here the disease more than 90% of the hemoglobin is sickle cell disease, right? So sickle cell disease, say for example 90%, exactly the 90%, then rest of the hemoglobin is just 10%. So out of the 100 RBC, 90 plus RBCs are sickle, hardly 10 RBCs are normal, right? So here you can remember in that less than 50% or less than 45% or half of the blood. What does it mean? If you have 45% sickle, HbS means out of the 100, 45 RBCs is sickle. Here out of 100, 90 RBCs is sickle. So more the sickle, more the problem. So amount of this sickle hemoglobin or HbS, right? HB is hemoglobin and S means sickle. HB is hemoglobin adult, fetal, minor adult, like that only, right? So HB, right, S is like the main differentiating point between the disease and trait. Is that clear to both of you? Yes or no?
Yes, sir.
Yes, sir.
Right. So say let's example sickle cell trait. It is supposed to be zero, but instead of zero, it's supposed to be 35 to 45% in trait. What does it mean? More the sickle, less the HbA, right? So this is reduced, no, obviously, because so what does it mean? Out of 4,500 RBCs, 45 is sickle
Mhm.
and 55 is a normal or adult hemoglobin, normal, just for your knowledge, right? So rest of the things are normal. Rest of the things are normal. There is no much abnormality in F and A2, right? In trait, the major thing is the amount of the sickle percentage of the hemoglobin in hemoglobin electrophoresis, and here 90%. So this is so here A2 is almost zero, almost zero. In sickle cell disease, hardly there is a normal adult hemoglobin, right? And rest of the things are most of the patients they are normal, right? So this is what the thing is. So what is the key difference in trait? So in trait has both HbA, right, and HbS, right? So they have in trait, they have HbA as well as HbAs, right? So that is why Hb hemoglobin adult and sickle. Here hemoglobin sickle only, no adult, almost close to zero. So this is HbSS. Is that clear to both of you? Yes or no?
Yes.
Yes, sir.
Wonderful. So this is the primary basic difference between sickle trait and sickle disease that
Okay.
you must remember
Okay.
and know, you must know, right?
Okay.
So that was the
Okay.
first thing. So let's jump to our question. What was our questions, right? So our question was that, right? So that was the question, right? So this is how you manage this case. So let me ask you, Dr. Fatima, if you're this patient in the emergency room, right, who is 9 years old, severe pain, 9 out of 10, these are the vitals, history, labs, right? How you supposed to manage? So you thought that okay, fine, this is sickle, right? Already is everything is given here, right? HbS is more than 90%, so this is HbSS on hemoglobin electrophoresis, right? So you diagnose that, sir, okay, fine, this is a case of sickle cell disease, right? Now how you manage this patient, how your algorithm will start in the emergency room, what you do the first, what you do the second, what you do the third, and why?
Considering the age and the symptoms, sir,
Hmm?
this is a case of sickle cell anemia with a pain crisis.
Yes, that's correct. So this is a case of sickle cell. Na? HB is more than 90. What else
Yes.
you need? Nothing. Patient has 7 grams of hemoglobin. It is given in the scenario. HB 7 gram
Yes.
person, clear cut. So you have sickle,
Yes,
you
sir.
have anemia, you have pain crisis. So this is likely a sickle pain crisis, right?
Yes, sir.
Mm. If you don't have the CBC, if you don't have the hemoglobin electrophoresis, it is likely, but it is not likely now. It is confirmed case, right? You have
Yes,
anemia,
sir.
you evaluated it's sickle cell patient has pain crisis. So how you manage this patient now?
First, we have to uh, s- start with oxygen,
Okay,
and we have to sedate the
let me write
patient.
down. Let me write down the patient. Sorry. So you are Dr. Fatima, right?
Yes, sir.
Yeah. And here I write down the management of Dr. Salika. Fine. So you go ahead, Dr. Fatima. What you do with this
We,
patient? What exactly? One,
first
two,
we
three,
have to
four, five. I will write down.
first we have to start with oxygen,
Okay, oxygen. Okay. First
and
question, why
we
you
have
want to start the oxygen? We'll learn this. Don't worry. You will never forget the sickle in your life. We'll learn each and everything. This question will
sickling.
100% come in exam.
Usually they used to have when they have hypoxia, sir.
Okay, so you have everything in front of your screen, dear doctor. 94%. Would you like to give it or not? You decide. You decide. You give your own
Yes,
answer.
sir.
So what you want? You want to give or you don't want to give?
We want to give, sir,
Fair enough. So you give the oxygen. Fine. What else? You started the oxygen to this
and
young
we
girl.
have to hydrate the
What?
patient.
Mhm.
We have to start IV fluids.
Hydration of the patient. So IV fluid you start with to the patient. Okay. Fair enough. You started the IV fluid. What else you want to do?
We have to give analgesics, sir.
Wonderful. So now you started the oxygen, you hydrate the patient, you give the analgesic to the patient. The next question, which analgesic?
Morphine is the drug of choice, sir.
Morphine is a drug of choice. Okay, fine. So morphine is a drug of choice. Right. So how you supposed to give to this patient? Oral, IV, or CPA?
IV, sir.
Sorry,
IV, sir.
IV. You want to give the IV to the patient. Okay. Right. What is the dose of morphine to this baby whose weight is 20 kg? Everything is in the scenario. This is what they practically ask you. Don't take it otherwise. How much dose you want to start with this patient? who is 9 years old and 20 kg. His liver function test is normal. Renal function tests are normal. The rest of the other investigation, basic labs and biochemistries are okay. Now tell me. Yeah, let's come to you, Salika. How you manage this patient? Forget about Dr. Fatima's management. You give your own management. Right? It's a learning. Are you okay? Are you enjoying? Yes or no?
Yes, sir. Yes, absolutely.
Wonderful. Wonderful. Yes, Salika.
Uh, I want to give O2, sir, because
You
airway breathing circulation comes first. So,
okay? So you want to
O2,
give O2. Fine. At 94, you want to give O2, or it's okay if you don't give? It's okay.
mm, less than 95%, in case of sickle cell disease, we are supposed to give O2.
Okay. So what advantage will happens when you give the O2 to this patient? And what is the disadvantage if you don't give the O2 to this patient? There must be something, na? That
Uh,
is why we are giving.
yes, sir. Because
Yes.
sickling, 90% sickling is there. So, oxygen delivery to the tissue will be reduced. So,
Wonderful.
oxygenation
Fair
will
enough.
improve.
Wonderful. So that is the logic of giving the fine. Fair enough. We'll see the real literature. No worries. So you had started the oxygen to the patient. What else you do?
Then IV fluids and for pain, morphine.
IV fluid
IV
and
fluids for
morphine. So
hydration.
same and fine. Fair
Same
enough. So again, same questions to you as well. Morphine, oral or IV?
IV, sir.
IV. Fair enough. What is the dose?
Uh, 1 milligram per kg in
1 milligram per
50
kg.
per kg in
1 milligram
50
per kg.
ml.
So this patient is 20. Let's write down. Na? This patient has 20
Okay.
kg, 20 kilos. So 20 milligram you want to give to this patient?
In infusion in a 5% dextrose solution
5% dextrose solution. How much ml?
and
100 ml, 200,
uh,
250, 500 ml,
50. I think 50 ml. 50 ml.
50 ml. Okay, 50 ml. And how you do? So you
And
give you finalize that I want to give 20 milligram dose to this patient whose weight is 20 kg. You diluted in the 50 ml of 5% dextrose. How you give now?
1 ml. Uh, 1 ml per hour. 1 ml
1
per
ml,
hours
1 ml per hour. That means this 50
per
ml,
hour.
50 ml will finish in 50 hours. Yes or no?
And yes, sir.
No, no. Yes. So,
Yes.
you want to
Uh,
continue this 50 hours means for 2 days you will give this dose 20 milligram you
uh,
give for two
I
days.
mean, we need to titrate. We need to increase. Depends upon patient pain level. Till the
Okay.
patient pain is reduced,
So
we
before
need to
starting the
increase.
so okay. So before start of morphine, the pain score is given 8 out of 10. 8 out of 10. 8 out of 10. Right before starting the morphine.
Yes.
After what time of starting the
Yes,
morphine
sir.
you will assess the score? Pain assessment after what time? So say for example, before starting it was 8 out of 10, right? You started the morphine
Maybe
immediately. After 30 minutes, 60 minutes, 120 minutes, 2 hours, 4 hours, 6 hours, 12 hours, right? Or 24 hours. When you
after
supposed to reassess the score?
after 30 minutes, sir. 30 minutes.
30 minutes. If I can say after
Yeah.
30 minutes pain score is 8 out of 10, same. Patient is saying I don't have any improvement. I have the same pain. What is your plan?
Then increase 1 ml. So 2 ml.
Okay, so 1 ml to 2 ml. Okay, right. Fair enough. If the pain is again the pain is same, right? After 2 ml it is 8 out of 10. What you do?
Okay. Uh, maximum dose, I don't remember, sir. Sorry.
No problem. So what is the maximum dose? Maximum dose, Dr. Fatima, maximum dose of morphine
Sir, the dose is 0.1 mg per kg, sir. I don't know the maximum dose, sir.
So 0.1 mg per kg. So she told 1 mg per kg. So it is almost 10 times the dose, isn't it? Yes or no by you? Because 0.1 multiplied by 10 is equal to 1 milligram per kg. Am I right or wrong? Yes or no, both of you?
Yes, sir.
Yes.
Fine. Fine. So we'll discuss. Don't worry. We'll discuss. I'm trying to make you understand what they're gonna ask you and how you supposed to answer. Fair enough. So can you tell me, Dr. Salika, what precautions or what things you will monitor while you are giving the morphine to the patient? Patient is on IV morphine now, who is a small kid of 9 years. Mother is very much educated and concerned, and she keeps asking you about the adverse event. And being a doctor,
Okay.
what precautions or what red flag signs you monitor while you are keeping the patients on IV morphine? Yes, Alika.
Yeah. Patient GCS, whether patient is sedation is the most important side effect, and respiratory rate.
Sedation. So
Well,
sedation would be
yeah,
there, right?
sedation.
Morphine sedation. Okay, fine, sedation. So if patient, right? Patient is little drowsy or sedate, right? After starting the morphine, you feel that patient is little sedated now. So are you going to stop the morphine?
Yes, sir.
You
Or reduce the
stop,
dose.
reduce the dose. So when you reduce the dose, right, pain is also increased. Na? When you reduce the dose, pain is
Increase.
increased. So what you do in this case?
Then like transfusion, sir.
Blood transfusion. But blood transfusion, do you think blood transfusion will reduce the pain?
It might
You
increase
started blood
the blood
transfusion.
flow.
Okay. Okay. So for pain, you use blood transfusion, Dr. Fatima? Whatever you are
Sir,
asking, telling me, I'm creating the questions from that only.
Yeah.
Hmm.
no, sir.
My question
Transfusion
is
is
that
not.
My
No,
question is that is blood transfusion will going to help in 8 out of 10 pain score because you are reducing the pain. You are worried about
no, sir.
sedation. No. So Salika is saying yes, you are saying no. We'll see, no worries, chal. Okay, fine. Now, if one is sedation, what other precautions you see or what are the bad side effects of morphine? What worst can happen in the body, like cardiac arrest? Worst. What worst can happen? IV
Respiratory
morphine, what worst?
depression, sir.
Respiratory depression. Yes.
I mean, if I can tell you worst, so worst is death. Worst is the death, right? Death can happen. Nothing
Yes.
worse than this, right? But anyway, what you need to remember is
Respiratory
for
depression.
respiratory depression. Okay, so you need to
Mm.
look onto the respiratory rate, isn't it? If the patient has a
Respiratory.
Yes, sir.
respiratory depression, means earlier the respiratory rate of this patient say supposed to be this baby has a 20, right? And now this become just 8 to 10, so respiratory depression is there, right? So you need to check on the
Yes, sir.
respiratory rate. What else, what third things you can monitor while you are giving the patients on the morphine? What else you monitor while patient
Uh,
is on morphine?
yeah.
Sorry, because you need to monitor na? While you started some critical drug like morphine, you
Yes.
had given the patients for the pain management. That's fine. Absolutely perfect answer. But you need to monitor, na? You need to monitor. Otherwise, patient will not die because of pain. He will die because of morphine. So you don't want baby to die because of drug side effect.
Um,
So what else you will keep in mind? Yes. Anyone? Yes,
any
Alika.
abdomen pains, sir?
Sorry.
Abdomen pain. Abdomen pain, gastric.
Abdominal pain. So abdominal
Yeah.
pain is fine. It's not very life-threatening
Very
abdominal pain.
dangerous. Yeah.
Mhm. Right. So if the morphine is not working well, is there any drug you can add to this morphine?
Uh-huh.
Or this is the only drug? Or if I can say, okay, fine, you want to start the morphine, but morphine is not available in your pharmacy, what do you do? You want to start morphine, but morphine is not available in your pharmacy, or it is out of the stock, and now patient in emergency with 8 out of 10 score, anemia, sickle crisis, what you supposed to do? It's not there. Would you like to give some another analgesics or something to these patients? Or there is no option, you need to bring and give morphine only. Very
Other
practical.
opioid,
Hmm? Sorry,
other analgesics, sir. Another opioid. Any other opioid analgesic?
another opioid
Like
analgesics.
codeine.
Okay. So what are that other opioids? What are that other opioids? Can you name some opioids when the morphine is not available?
Codeine.
So, codeine. Okay. What else?
Sir, meperidine, sir.
Tramadol.
Tramadol. What else? So you both read the complete chapter, spend 1 hour on opioid analgesics tomorrow, right? And tell me. Fine, fair enough. So let's start with this. Let's start with this. So what? Let's go to the discussion further. Yes, doctor. One by one questions you both have to answer. First questions, Dr. Salika, and then Fatima. Yeah. So what is the diagnostic test for sickle cell disease or sickle cell this disease? Yes, tell me.
It's hemoglobin electrophoresis, sir.
Hemoglobin electrophoresis. We'll see the treatment. Fine. Pain management we are seeing. Long-term curative. Fair enough. So hemoglobin electrophoresis is the treatment or sorry, investigation of choice. Okay, Dr. Fatima, tell me treatment. So you told the oxygen, you told the IV fluid, you told the morphine, but you still did not get the exact clarity how morphine has given, what is the dose, what are the precautions, right? When the morphine does not work, what is the alternative drug? Yes or no?
Yes,
Anything
sir.
else you want to give? Oxygen you had given, IV fluid given, morphine we'll discuss in detail because they will ask you this MC questions 100% in exam. So we want to dissect it a bit more. Apart from this, would you like to add anything on this management of this patient?
Yes, sir. Antibiotics.
Antibiotics. Okay. Why you want to add antibiotic? Or what are the indication of antibiotic? This patient is now not in fever. Still you want to give the antibiotic? Or what are the
Yes, sir.
indication of using the antibiotic in sickle cell disease? Tell me now. So first we decide whether
Repeated crisis.
repeated crisis. Okay, so the repeated crisis is the indication for antibiotic.
Uh, they have. Can you say?
Yeah, both of you can answer, no problem. I want to understand the concept. Is antibiotic is
Patient.
required in all sickle cell disease, or is there any specific indication of using the antibiotic in sickle cell disease?
Patient will have autosplenectomy, so they are more prone for uh, capsulated organism infection and more prone for
Wonderful.
sepsis.
Okay. Encapsulated. Can you tell me the name of encapsulated organism?
Pneumococcus,
One is pneumococcus. What else?
then meningococcus,
Meningococcus. What else?
then Haemophilus influenza. Am I right? I'm not sure. Haemophilus
Fair enough.
influenza,
You
I
are
think.
going well. So Haemophilus influenza type B, right? So these are the three Haemophilus influenza type B. So these are the three organisms, right, which increases the, right, when you have autosplenectomy, right? How did you get to know that this patient is going to the autosplenectomy? What do you mean by
Um,
autosplenectomy?
uh, this patient is 9 years old. So mostly, she said she had repeated infections, repeated
Mhm.
crisis since childhood. So most sickle cell patients by 5 years, they will have splenectomy, after splenectomy.
So what is the difference between autosplenectomy and splenectomy?
Um, Splenectomy is a surgical removal of spleen. After
Wonderful.
splenectomy is uh, due to mm, repeated splenic sequestration of the immature, repeated insult to the spleen, and uh, it becomes
So basically,
dysfunctional.
yeah, you are absolutely right. Absolutely right. So I got the idea what you want to convey me. So splenectomy is a surgical procedure where you are, right, either by open or by laparoscopic, you are getting the spleen out of the body. That is called splenectomy. And autosplenectomy is without operation because of chronic ischemia to the spleen. Spleen gets died. Is that clear? You don't need to
Yes,
remove
sir.
it,
Yes.
right?
Yeah, yeah.
Because of chronic ischemia, chronic sickling in the splenic pulp. So gradually chronic insufficiency of the blood supply. Any organ need blood supply to survive. Simple. If brain does not get blood supply, stroke. If heart blood muscle does not get blood supply, cardiac arrest. If the lung does not get blood supply, pulmonary embolism. Are you getting me? Yes or no?
Yes, sir.
Likewise, if the spleen does not get blood supply, autosplenectomy or spleen is gone. The spleen is there inside the body, but it is not functioning, right? So it is autosplenectomy. So what organism is most common in such patients? What organisms are more common when you have sickle cell disease patient comes with a fever? Which organism you target for the antibiotic? How you select the antibiotic, which antibiotic to give, which group to give, right? Because there are thousands of antibiotic
Yes.
is there. Which antibiotic you want to give? Levoflox, you want to give micacin, you want to give meropenem, you want to give tigecycline, you want to give pipzo, you want to give cefepime, you want to give ceftriaxone, you want to give cefotaxime. How you supposed to manage, how you supposed to decide what antibiotic has to be given? Yeah, Fatima. Yes.
Ceftriaxone, sir.
Which antibiotic?
Ceftriaxone.
Ceftriaxone. Okay. Which group of drug it is? Ceftriaxone.
Cephalosporin, sir.
Cephalosporin. How many groups or how many generation of cephalosporin now available in the market?
4.
Sorry,
4, sir.
four. Okay, not five. I know that it is five or four. Fine. So go and read it. Both of you have to give me the homework every day, right? Whatever I'll give you, right? So first homework is sickle cell disease, how to manage. Go and read it either from our website or from our PowerPoint or standard books, right? How to manage the
Okay.
sickle cell disease. Second homework was that, right? How you I mean,
Yes.
what are the indication of antibiotic in sickle cell? Third thing is complete logistic about the morphine, complete, right? So let's jump to the first things, then we will discuss a lot of things, right? So this diagnosis is sickle cell disease, painful vaso-occlusive crisis. Clue Key clues for the vignity or clinical scenario is that recurrent episode of acute severe limb pain lasting 3 to 4 days, Right now, no fever or no signs of infections because WBC they had given normal. There is no fever now. Hemoglobin is 8, MCV is 83, hemoglobin electrophoresis is more than 90% HbS and no HbA. Confirms the sickle cell anemia. So there are two words. Whenever you are using sickle cell anemia, right? So you have two things. Sickle cell, one is sickle cell, right? How did you get to know HB is more than HbS is more than 90? So it is a sickle process. Anemia, the definition of anemia, you know, right? So this lady has a 7 grams of HB, so it's an anemia, obviously. So this is sickle cell anemia, right? So this presentation is classical for vaso-occlusive. Vaso means vessel, occlusive means blockage, and because of the vessel gets blocked because of the sickling, ischemia and ischemia pain, the tremendous pain like chest pain, when the muscle of the heart does not get blood supply well from the coronary artery muscle of the heart are dying, and that is what we are calling it as a acute myocardial infarction. Here tissue is not getting, especially the small vessel gets affected here. So vaso-occlusive pain crisis, there are a lot of complications, one of them is pain crisis, right? So that's it for this thing. Now let's see little more forward, right? So these are the algorithm, right? This is the standard algorithm for treating the sickle cell management. So there are four steps in the management. One is the relieve the pain, right? Patient has a too much of pain, right? Second is to maintain the hydration. Third thing is to rule out the trigger like stress and infection. And fourth thing is prevent the complication, right? These are the four common things. When patient comes to you with a severe pain, manage the pain, right? Obviously, hydration is cornerstone of the treatment, right? Trigger, look at the trigger. What, because of what this sickle cell happen? And once he is fine, absolutely okay, you want to prevent the complications. And here I can add one thing is a recurrence as well, right? So you want to prevent the complication as well as you don't want this patient again comes with the recurrence after 3 months, again pain score 8 out of 10. Are you getting me? Yes or no?
Yes, sir.
Yes.
Right. So immediate number one is not relieve the pain, right? So immediate management of acute vaso-occlusive crisis or pain crisis. Start NSAID if mild to moderate pain, right? Our patient is not mild to moderate pain. Our patient is a severe pain. 7 or 8 out of 10 is severe pain, right? Moderate to severe pain, and moderate to severe pain, the opioid analgesic is a treatment of choice. One is IV morphine or hydromorphone. Remember simply morphine or morphone, morphine or morphone. It's a hydromorphone, right? So IV morphine. So I told ask you the question, if the IV morphine is not available, what you supposed to use? Hydromorphone, right? With reassessment of pain score every 20 to 30 minutes. So you can't see it every 3 hourly, 6 hourly, 12 hours. Every 15-20 minutes you need to recheck the pain, right? After starting the IV morphine or hydromorphone. Is that clear to everyone? Yes or no? Right?
Yes, sir.
Hydration. Hydration
Okay,
is
sir.
IV fluid. IV fluid usually isotonic. Isotonic means normal saline at the maintenance rate. Right? This prevent the further sickling, right? But avoid the overhydration. So you need to see both the things, right? Pros and cons. So you need to give the good hydration with the normal isotonic saline, right? So this is job is done. Oxygen supply, as per the literature, as this patient has more than 99% oxygen, no oxygen is required. No oxygen is required at this point of time, right? So fourth is a warm compression. Fourth is a warm compression. So help the muscle relaxation and reduce the sickling, right? So cold increases, warm reduces, right? So you need to do the warm compression, right? So it is very important at the site of the pain. At the site of the pain, you do the warm compression, right? So another thing is, right, so you did the pain control with the morphine. We'll see absolute in detail morphine. This is just the beginning. So you started with the morphine or other way around. When patient comes, right, you start with the hydration, you give the morphine. That's fine. It's okay, fine. So don't get confused, right? Oh, sir is saying first pain and then hydration. It's fine. When patient comes the emergency, Morphine you cannot have immediately within 1 minute is available. So take IV line, start IV fluid, and get the morphine. That's it. Are you getting me? Yes or no?
Okay,
Right?
sir.
Yes, sir.
Yeah, so one compression, check for the common triggers. So common triggers are infection. If it is there, you treat it. Dehydration, we are already started the hydration, right? If patient has stress, you just try to make them cool and calm. And cold exposure. Cold exposure is a right cold exposure. Why trigger? Because cold exposure increase the sickling, right? And you want to reduce. So reverse, right? So remove the cold. So give the warm, right? So it increases sickling by vasoconstriction. This may cause vasodilatation. It prevents the sickling or it reduces the sickling, right? So this is what the basic things we need to know about the sickle cell things. Now let's come to the real story of morphine. So this is absolutely high end things I got it for you. So morphine in a sickle crisis. It is number one. I started my journey in Muscat in Oman in a few years back. They asked me these questions, right? The same questions I'm discussing with you. Sickle cell crisis. They asked me in my exam in Oman Viva in Muscat, right? So why morphine? So morphine is first line, IV morphine. If morphine is not available, I told you, hydromorphone. Is that clear? Yes or no? Yes or no?
Yes,
Okay, sir.
yes,
Morphine is a first line opioid analgesic. This is opioid analgesic for moderate to severe pain. So if your pain score is 1 out of 10, does not required. 5 out of 10 does not required. Right? 6 out of 10 in problem is not required. But severe pain, say 7, 8, 9, 10 out of 10 is severe pain, right? So this is a pain score, right? You must have seen the picture, right? This is absolutely fine, then this is little low, then this is absolutely low, and 10 out of 10 is like crying, and this is this like this. Have you seen such a picture of the pain score? Yes or no?
yes, sir. Yes,
Right? So you go
Yes,
and
sir.
check the pain score. If you have really don't know the pain score, it is the one of the vitals now, along with temperature, pills, respiratory rate, and BP. Pain should be included in the vitals. You must check the pain score every patient, every emergency room. So it is right. So it is maximum score is 10. So you look into it pain score. So this is also your homework. I will ask you both of you tomorrow. You have to tell me from your side upfrontly. You have to be proactive, right? So morphine is a first line opioid analgesic for moderate to severe pain in a sickle cell vaso-occlusive crisis. Why morphine? Why morphine? That's the question. So it is a strong, it is reliable analgesic effect. So it's a strong and reliable effect. Number one, it has a longer duration versus fentanyl. So fentanyl has a short duration, morphine has a long duration, right? It is effective in recurrent severe vaso-occlusive crisis and safe when titrated correctly. So its safety profile is also time tested. For many years, it is used drug of choice, right, for the sickle cell crisis. So it is when you used it properly, judiciously with a proper dose and titration, it is safe drug, right? If you give it unmonitored, you give a very high dose, then it is not safe. But it is written here safe when titrated correctly, right? So are you getting me what I'm trying to explain? Yes or no?
yes, sir.
Wonderful. So now let's see, there is another technique as well. So now we see the how to use morphine in vaso-occlusive crisis. We are talking about our patients only. So what is the route IV is preferred? There are a lot of questions, right? So we'll solve one by one, right? Right now we are not going much with patients controlled analgesia. We'll talk about it. So we are talking about morphine now. So morphine IV is preferred. So one problem is solved. Second question comes, sir, what is the dose of the IV morphine? Right? So initial bolus you can give, bolus like which you can give 0.05 to 0.1 milligram per kilogram IV. So here I think there is some disturbance on the background. So 1 milligram per kilogram is absolutely the wrong dose. Absolutely the wrong dose, right? So there are two doses. One is IV bolus or initial. When patient comes to the emergency room, it's an initial, and then continue infusion if needed. When continuous infusion it's needed, so you need to mug up somehow. You need to mug up. So this dose, somehow somebody told me 1 milligram, it's absolutely wrong. Bolus you need to remember is 0.05 to 0.1 milligram per kilogram IV. So let's talk about this patient. If you want to give maximum 0.1 milligram, our patient has a 20 kg, so dose is 2 milligram per IV you have to give as a bolus. Are you getting me? At least tell me yes or no.
Yes, sir.
Yes, sir.
Dr. Salika clear?
Yes, sir.
Dr. Fatima clear? Right?
Yes,
So,
sir.
so IV bolus you have to give in this dose, right? This is maximum dose. I calculated 0.1 milligram per kilogram IV, so kilogram is 20. So 20 multiplied by 0.1 is equal to 2 m, right? Milligram dose you have to give IV to this patient. Once you started the dose, next question, when you supposed to reassess? Reassess, as I told you, every 15 minutes you have to check the pain score, right? 8 out of 10, 7 out of 10, 6 out of. So if it is improving well and good, you continue. And repeat small bolus until adequate analgesia. Repeat small bolus until, repeat small bolus until adequate analgesia means pain control. You have to repeat, right? And once, say for example, at this point of time, patient does not improve after 15 minutes, right? Then you, what they are saying, repeat small bolus. Small bolus means this could be a small bolus. Smallest bolus is this, right? So 0.05 multiply by 20. If you remove this, it is 100, right? So 5 multiply by 10, it is 1 milligram. So you repeat 1 milligram after 15 minutes, right? So here 2 milligram, now 3 milligram, then 1 milligram, 4 milligram, right? You can repeat the small bolus every 15 minutes. Are you getting me? Yes or no? You need to tell me yes or no.
Yes, sir.
Yes, sir.
Wonderful. So once at the stable point, you started at the 2 milligram, and every 15 you're increasing, and now it is 5 milligram you reach, and now patient is saying me, okay, fine, I'm absolutely fine, my pain score is now 1 or 2, I have much relief in the pain. So that's it. Then you don't need to give the bolus, then you need to give continuous infusion if needed. What is the dose of this? What is the dose of this? 0.02 to 0.05. So here the bolus lowest dose, here the highest dose. Remember in that way, right? 0.05 to 1 milligram per kilogram IV, here 0.05 milligram per kilogram, and here R. The difference is R. So let's discuss here. So here 0.05 means what? 0.05, right? 0.05 milligram per kilogram. So 20 kilogram, right? So here 1 milligram per R you have to continue. Is that clear? Yes or no? Is that
Yes,
Yes,
sir.
clear?
sir.
100% this question will come in exam. Look at this all slides repeatedly. It's all with yours, don't worry. So now the route is decided. What morphine, right? So morphine is IV. Dose is this bolus. Once the pain is controlled, continuous. If you need it, if needed, this is the dose, right? So this is two things is confirmed. Now let's jump to the third thing. Route is okay, dosing is okay. Now third thing is adjustment of the morphine, right? How you supposed to adjust the morphine, right? So morphine adjustment, right? Use, right? Sorry, not adjust, adjunct to the morphine. Adjunct to the morphine means morphine plus any other drug which you can use the another drug, right? So use multimodal therapy. NSAID unless contraindicated. NSAID like ketorolac, right? You can use as an adjunct, means along with the morphine. You don't need to remove the morphine, right? Even if the pain is there, you can add the ketorolac. IV fluid, we already seen it. Warm compression, when we seen it, and the trigger we seen it already, right? This is what my question is. When patient was on morphine, what you supposed to monitor, right? Monitor on morphine, continuous pulse oximeter, Why? Because patient may go into the respiratory depression and may develop hypoxia. So oxygen saturation is important, number one. Respiratory rate for the hypoxia, hypotension, sedation score is important. So look at the respiratory rate, look at the SpO2, right? Look at the pruritus, right? These all are the complications of morphine, basically nausea, vomiting, and constipation, right? But the fatal one is the respiratory one, right? Fatal one is the respiratory one. So respiratory depression is leading cause of death patients on morphine. So you need to check for the respiration, oxygen saturation, respiratory rate, right? So this is what the important clinical notes for this. What are the important clinical notes for the morphine, right? So important clinical notes for the morphine, right? You Meperidine is a this opioid, but you avoid it. Why? Only one reason: it can increase the risk of seizure. So this is the only drug from the opioid you cannot use it for this reason. They will not ask you, but just for knowledge, right? So do not withhold. So what is the important clinical notes for the sickle cell pain crisis, vaso-occlusive crisis? Do not withhold the opioid. You must give it opioid. You must give it. You should not withhold. You should not stop the opioid. Sickle cell disease patients often have high opioid tolerance. Under treatment is common and harmful. Under treatment is harmful, and it is very common. People are afraid of giving the morphine. They are afraid of respiratory depression. They are afraid of a lot of side effects. What they have heard, they never used it. So it is under treatment is common and harmful because you don't give the justice to the patients by under treatment, underdose it. Pain is not controlled. So use freely with the proper titration. Use freely. It is safe drug when you use it properly and titrate properly. This is one take home message. So sickle cell disease, give morphine, right? Do not withhold it, right? Give it with the proper titration and monitoring. Usually this is literature. Oxygen saturation when less than 92 or hypoxia, give oxygen. So 94% oxygen in our patient. If you cannot give, that's fine. It's fine, right? So give oxygen,
Okay, sir.
otherwise not needed. Otherwise not needed. So when there is a because anything more than 93, 94 oxygen carrying capacity, oxygen is fine. So adding the oxygen will not add much value. Yes, but if it is hypoxia, answer is yes. You must have to add the things in it, right? And reassess frequently. Every 15 minutes, pain should improve within 20, 15 to 30 minutes in general, if you want to remember, right? For adequate dosing. So if the dose is not adequate, you have to increase every 15, 20 minutes. Is that clear to you? Yes or no? At least tell me yes or no.
Yes, sir.
Yes.
Right. My question was also that what do you do when the pain is not improved, even with the morphine, right? So when the pain does not improve, considered it is not just the vaso-occlusive crisis, it could be acute chest syndrome. Consider there is some occult infection or patient has tolerance to the opioid, and that is why you need a more dose, right? They are not improving well, right? Escalate the dose sensibly, consult the hematology, and evaluate for the complication, right? So, last but not the least, the quick exam summary is morphine is a first line opioid for moderate to severe pain, especially we know vaso-occlusive crisis. Do not utilize well with the proper monitoring and titration. Bolus dose you should know, intravenous route you should know, maintenance you should know, and what are the common adverse effects or events can happen that you should know. That is all what we discuss. Is that clear? Yes or no?
Yes, sir.
Right. So this is the things related with the morphine. So probably it's not in the book. I need to get a lot of things and then compile together, right? So, but you can watch this video later on. So these are the common complications of stroke. Sorry, sickle cell disease. So sickle cell disease complication stroke, right? This is brain. So this is vessel in the brain, right? So this is vessel in the brain which is occluded because of sickle, and patient may present with the ischemic stroke, central nervous disease. right? So this is picture, right? This sickle, it is not supposed to be this. This is supposed to be like this, right? So let me draw this normal RBCs like dumbbell shaped biconcave and right, which is very much flexible, and this is sickle. This is sickle. They can easily right, they adhere and they occlude, right? They lost their flexibility, so they cannot very smoothly travels to the vessels, especially the small vessels, capillaries, right? So one is the brain. So patient may present with the stroke, ischemic stroke, right? Patient have lots of chronic ischemia, right? So they have acute widespread chronic pain because of chronic ischemia, especially in the small blood vessel, like in the extremities or in the brain or in the lower limb. They have the ulcers and all. Recurrent hemolysis can cause the jaundice, right? They get concentrated in the glomeruli and cause the kidney problem, and there is a cardiovascular or cardiopulmonary disease, right? Like they may have acute chest syndrome, acute hypoxia, patients present with acute chest syndrome, right? And a lot of things, right? So these are the general understanding. So wherever the blood vessel is there, everywhere sickle cell can create a problem, right? So that is the things, right? So again, the long-term management, right? So long-term management, right? So we have seen how to manage, right, sickle cell. So first you have to diagnose the sickle with hemoglobin electrophoresis. Then you have to give the treatment. In treatment, one is hydration or pain management with the morphine, right? Another is hydration we have seen, right? And other supportive care as well, along with that, antibiotic and all blah blah, right? This is general understanding, right? So you have treated the pain, you have hydration, right? Then you have to prevent the long-term complication. Long-term management is also there, right? So how you do the long-term management? So first and foremost drug is the hydroxyurea. Hydroxyurea is usually indicated for the recurrent vaso-occlusive more than 3 crises per year. So some patient has more than 3 crises per year, they deserve the hydroxyurea. Hydroxyurea absolutely a wrong answer in acute pain crisis. It does not reduces the pain at all. So it is a wrong answer in acute pain crisis. Then that is why we did not discussed along with the morphine. It has nothing to do with the pain. Then what exactly how it does? What do? It increases the HbF, fetal hemoglobin, and this is how it reduces the sickling. So it has no role in reducing the even sickles, HbS, HbA, nothing. It increases the HbF, and that is how it reduces the sickling. Folic acid supplementation, right, is lifelong, right? It is long-term management, long-term, not acute management, long-term. Once the sickle cell disease and sickle cell crisis is over, right? How you long-term manage this patient? So hydroxyurea, I had given you the criteria and what exactly it does. It is folic acid supplementation because it supports the RBC production. So in folic acid deficiency, RBC cannot form. So you don't need to. I mean, you don't want the folic acid deficiencies to happen. So give the folic acid. Vaccination is important in the long term because autosplenectomy, as already told you by Dr. Salika. So you give pneumococcal, you give meningococcal, you give Haemophilus influenza type B vaccine. So this all encapsulated organism and penicillin prophylaxis, especially in a younger children up to 5 years, you can use it because they are more prone to immunity is low. They are more prone to get infections, pneumonias, right? So this all vaccines are important. Educate the people, adequate hydration, early treatment of fever, right? And warning signs, right? Why adequate hydration? Because when there is a dehydration, sickle crisis. When there is a fever, sickle crisis. So basically, try to reduce the stress. Whatever the things which can worsen the sickle cell crisis, you try to reduce it. And regular follow-up with the hematologist is also important part of the treatment and management. So before complication can happen, hematologist can compile. So what is a summary? Sickle cell disease presenting with the recurrent vaso-occlusive crisis. IV hydration is very important. Opioid analgesic for severe pain like morphine. NSAID as an adjunct, not the first line. No oxygen unless hypoxia means less than 92. You give it, more than usually not required. monitor for complication, and start long-term treatment or disease-modifying therapy like hydroxyurea, which probably reduces the complication of the things. Right, so that's it for these things. Now let me give you the idea about this, uh, the other few basic things about it. So before ending up my session, I have 15 questions for you. So first questions, are you getting me, both of you? Are you with me? Yes or no?
Yes, sir.
Wonderful. So 15 question. First question, what is sickle cell disease? Sickle cell disease is a hereditary autosomal recessive hemoglobinopathies due to mutation in the beta globin gene. Right. So there is a problem in beta globin gene, sorry, and causes chronic hemolytic anemia, vaso-occlusive crisis, and many things. So sickle cell disease is basically autosomal recessive hemoglobinopathies. What precipitate a vaso-occlusive crisis? All questions are very simple but very important in the practice as well as in the viva. So what precipitate means what increases the vaso-occlusive crisis? So all stress, these all are the stressors, right? So dehydration, right? Infections, cold exposure, hypoxia, stress, and acidosis. So you need to remember. So these are the conditions. So any patient is of sickle cell disease, he is otherwise fine, treated well. But if something comes amongst this, sickle can precipitate. It can precipitate. It increases. So what is sickle? What is how and what precipitate the crisis? How do you diagnose the sickle cell disease? Third question. So it is done by the hemoglobin electrophoresis. Almost the normal hemoglobin, that is HbA, is completely replaced by HbSS, right? Peripheral smear, you can see the sickle things, you can see the target cell, and CBC, you can see the normocytic anemia with increased reticulocyte count. So reticulocyte count is increased because of hemolysis, right? Red retic count is forming increase, right? So whenever you have hemolytic anemia, the retic count is usually increased, except if the bone marrow is doing the ineffective erythropoiesis where it is not increased. Otherwise, most of the hemolytic anemia, you have increased reticulocyte count, right? So third question, fourth question, what are the type of sickle cell crisis? So what we have seen amongst all, right? So they may ask me in exam anything, but this is the one of the most, that is why we discuss this. So vaso-occlusive crisis, right? Aplastic crisis. So there are a lot of things. What is the definition of aplastic crisis? How the aplastic crisis happens in sickle cell? How you manage the aplastic crisis? How you investigate and diagnose the aplastic crisis? How you can prevent the aplastic crisis, and long list, right? So I'm just trying to give you the idea and clue how you supposed to think, right? So we discuss at length with hydration, with morphine, right, with long term management of this, that is for vaso-occlusive or pain crisis. Same way aplastic crisis, usually parvovirus can cause this aplastic crisis. Sequestration crisis means there are a lot of pooling of the blood or of sickle RBC or splenic pooling, so it can cause sequestration crisis. Hemolytic crisis means blood gets broken down, so hemolysis develop very fast because of infection, fever, dehydration, hypoxia, acidosis. There is a fast sickling happen, and because of fast breakdown, there is a hemolytic crisis. Hemolytic crisis. So say for example, before 3 days, patient's hemoglobin is 10. Now he present in emergency with 4. Hemolytic crisis. Hemolytic crisis. Hemolysis. Hemo means blood and lysis means breakdown. So breakdown of red blood cell RBC is hemolytic crisis. And if this sickling happens in the chest, it is acute chest syndrome. It is life threatening. So amongst all the whole list given, this is fatal. All are fatal, but this is the highest fatal. So you need to completely concentrate and you need to address the condition well. So what four questions we have seen? What is sickle cell? What precipitate vaso-occlusive crisis? How you diagnose? What are the complications? Fifth question, how do you manage acute pain crisis? We have seen it, not going in detail. Analgesia, hydration, oxygen if hypoxic, infection if there is a signs of infection, fever, CBC culture, chest X-ray. Use it, warm compression, right? It reduces the sickling and reassure the patient. Six, what is a chest syndrome? It is important. Definition is important. new pulmonary infiltrate, new pulmonary, not the old, new pulmonary infiltrate plus more than one of what? Patient has fever, patient has chest pain, patient has wheeze, patient has cough, or patient has hypoxia. So there are five things, not one thing. There are five things. You don't need five things. One, two, three, four, five. So if you had a patient's X-ray, right? Patient X-ray, and there is a new infiltrate is seen on the X-ray plus only one of five. So new infiltrate plus fever, it's acute chest syndrome. New infiltrate plus chest pain, it is acute chest syndrome. New infiltrate and wheezing, acute chest syndrome. So this is the fixed criteria. New pulmonary infiltrate, which was not there earlier, or new pulmonary infiltrate with one of the symptoms. This all symptoms. Patient come and tell you, I have fever, I have chest pain, I have difficulty breathing, I have cough. Hypoxia we can evaluate with a pulse oximeter. So this patient present. So how you supposed to manage? Acute chest syndrome means it is a difficulty with the oxygen, right? So oxygen is number one treatment. Broad spectrum antibiotic, especially ceftriaxone and azithromycin, sorry, right? For the pain management, incentive spirometry, and exchange transfusion if severe. Exchange transfusion, extremely important. This is homework. So this is another homework. What is the exchange transfusion? Write down the homework. What is the exchange transfusion? Exchange transfusion. What is the exchange transfusion? Right? Where? What are the indication of the exchange transfusion? Indication of exchange transfusion. Yeah, and what is the advantage of doing the exchange transfusion? That's it. I don't want you to do a long research. There are 100, we can take
Okay.
one lecture on only just exchange transfusion, one whole lecture. We just need a practical point of view to pass the exam. What is exchange? If they ask you, na, okay, doctor, patient is come in the acute chest pain crisis, right? So acute chest syndrome or acute uh, chest syndrome, right? So it is one of the most after the veno-occlusive or after the vaso-occlusive crisis. Acute chest syndrome is one of the most commonly asked question in exam. So they may ask you, okay, this patient, if what happens if this patient comes with a fever, new infiltrates, cough, right, difficulty in breath, doing a hypoxia, how you manage? In that case, they may ask you this question, right? When you say, I give the oxygen, I give analgesic, I give the hydration. So primary, this vaso-occlusive or pain crisis management will applicable to all. But the specific in chest syndrome, acute chest syndrome, is two things. One is oxygen, and second thing is exchange transfusion. So they probably ask you, okay, tell me, doctor, have you ever seen which exchange transfusion? What do you mean by exchange transfusion? What are the indication of exchange? So we should not go blank, right? Is that clear? Yes or no?
Yes, sir.
Yes or no?
Yes, sir.
Yes, sir.
Wonderful. So that was the sixth question. Seventh question is what is the splenic sequestration? These all are the complication, isn't it? Pain crisis, chest syndrome, splenic sequestration, hemolytic crisis, right? And aplastic crisis. So what is the splenic sequestration? Rapid enlargement of the spleen. How come the rapid enlargement? Lots of these sicklings are happening now in the spleen only. That is why it is a splenic sequestration, not the liver sequestration, because everything, all sicklings is in the spleen. So rapid enlargement of spleen, sudden drop in the hemoglobin, hypotension or shock, management is of shock. IV fluid, obviously, urgent blood transfusion, yes, because of this sudden drop in hemoglobin. So how you gonna fastly increase the hemoglobin? By blood transfusion, right? And to prevent recurrence, you can go for the splenectomy. So when there is a no spleen, there is no sequestration. What is aplastic crisis? So aplastic crisis, like aplastic anemia here, aplastic crisis. So severe anemia plus a low retic count. This is the difference. Aplastic crisis means nothing happening. Severe anemia, usually when there is a no aplastic crisis, just hemolysis in sickle cell, low hemoglobin, increase retic. Aplastic, low hemoglobin, low retic. Is that clear? Yes or no? Most commonest cause is
Yes,
parvovirus.
yes.
Manage supportive care, right? Supportive care includes IV fluid, and if pain is there, pain management, blood transfusion, exchange transfusion, blah blah, you can use it, right? What complication do you look for in a sickle cell child? Stroke, yes, because of brain. Acute chest syndrome, sequestration crisis, functional asplenia, that means autosplenectomy, increase the risk of infection, pneumococcal, meningococcal, H influenzae, Osteomyelitis, the commonest organism is Salmonella. Avascular necrosis of hip, chronic hemolysis can create a gallstone, right? Chronic kidney disease, priapism, retinopathy. So we knows all this, right? So that was the ninth question. 10th question, what is the long-term management of this patient? Hydroxyurea, as we seen it, it is not reducing HbF, it increases the HbF. It does not reduce HbS, it increases the HbF, hydroxyurea. More than 3 crises per year, they deserve it. Folic acid lifelong, penicillin up to 5 years, vaccination against 3 vaccines. This is what the long-term management and screening, right? For the stroke, eye, and kidney. So you can keep patients under close observation. Why is the salmonella common in sickle cell disease? Very important, interesting questions in sickle cell disease with osteomyelitis. Repeated micro-infarct in the gut or bacteria, right? And functional aspenia, poor clearance. So these are the two reasons why salmonella is common in sickle cell osteomyelitis, right? So it is important 12 question. Why do sickle patients gets gallstone? Because in sickle cell there are lots of hemolysis, hemolytic anemia, hemolytic increase the bilirubin, bilirubin gets deposited in the gallbladder as a pigmented stone or bilirubin stone. So gallstone is very common. The mechanism I told you for question number 14. How does the hydroxyurea work? So it does not reduces the HbS, it increases the HbF means fetal. It reduces the sickling, it decreases the vaso-occlusive crisis and acute chest syndrome. Side effects, myelosuppression, monitor CBC on regular basis, initially weekly, then 2 weekly, then 4 weekly. What are the indication for exchange transfusion? Your homework, but I'm telling you now, but you go and read it once again. Severe acute chest syndrome is number one complication or number one indication of exchange transfusion. Severe acute chest syndrome, stroke, multi-organ failure, pre-op for high-risk surgery like brain surgery. If you're operating on the brain in sickle cell, you need to think of it. Priapism, refractory to the therapy, and last but not the least, why avoid meperidine in sickle cell disease? Because it may precipitate the seizure. And last but not the least, hemoglobin electrophoresis is done to diagnose any kind of abnormal hemoglobin, right? So sickle cell trait versus disease, trait and disease, the biggest difference is amount of the sickle red blood cell in the blood. If it is less than 50%, it is trait. More than 90%, right, is HBSS. This is adult plus sickle. This is all sickle. So it is SS, right? So that's all from my side, I think. So concluding our talk, right? What we learned so far in this lecture is that how we supposed to manage the sickle cell disease in general, right? Is not very these things, but these are the common topics we heated what they asked. So how you manage this patient? So this is a one-liner answer is that so this is scenario given to you by the expert or by the teacher, right? Who is asking your interviewer or your Viva teacher, right? So once they give this, you have to answer in that is. So considering this scenario, this young girl is suffering from the sickle cell disease with acute pain crisis. So I would like to treat this baby, right, with the starting the IV fluid, giving the morphine, right, giving the IV fluid, giving the morphine, and if the patient here the counts are normal, so I probably avoid the antibiotic. But if there is a history of fever, history of high count or leukocytosis or source of infection, I would like to add the antibiotic. Once patient gets settled, I will going to do the long-term management for the patient, right, for the prevention of the recurrent attack, right? So whatever you tell, they will ask you the question, okay, what analgesic you use, then you should not tell morphine. What is your answer is supposed to be for morphine? So for this young girl is suffering from the 8 out of 10 pain score, means she is in a severe pain. So I would like to start with the IV morphine with the dose of 0.05, right, milligram per kilogram, right? And I will monitor these patients every 15 minutes, see if there is a no improvement in the pain or pain score does not get reduced. I will escalate my dose, right, to the maximum where she get a pain control. And once there is a good pain control, in next couple of hours, or earliest I will switch for the continuous morphine infusion with the same dose of 0.05 milligram per kilogram per hour. Here the difference is R per hour, with the close monitoring to the respiratory system, because the commonest complication of IV morphine is the respiratory depression, hypoxia. So I will look into it. And they may ask you at this point of time, if respiratory depression happens or occurs, what is the antidote? What is the antidote? What is the antidote of morphine? They quickly ask you the
Naloxone, sir.
some curiosity question.
Naloxone.
Yes, sorry, Ska, what do you think?
Naloxone, sir.
Naloxone. Salika is there in the class or not?
Yes, sir.
Fine, fair
Yes.
enough. Fine. So do you know the antidote of the morphine? So go and read it.
Morphine,
Go and read it.
okay, sir.
Go and read it. Right. So that's all from my side. So I think you got the idea what exactly we did for last almost now 60, 70, 80 minutes we are discussing on this, right? So you get the idea.
Yes.
Now you tell me your
Yes, sir.
feedback, Dr. Salika and Dr. Fatima. Yes, you give me some feedback.
I,
Yes, please. Yes. What's your feedback for today's class?
Sir, very well explained, sir.
sir, yes. What can I say?
It's
Sorry?
full lecture, sir. It's actually a full lecture of sickle cell from top to
I
bottom.
Yes,
mean,
complete.
From
Yes, sir.
basic to end till treatment and follow up, everything is covered, sir.
yeah, because they
Yeah.
gonna ask you everything, right? See, they gonna ask you
Okay.
anything.
Okay.
They are not asking as per Dr. Munjal's class, right? So I want to
Yes.
make the all classes by me and my coach as transparent as what they are asking. And I practice myself in many countries, so I know how they ask what they ask, right? You understand? So we don't need to mug up. We need to understand the practical. So now you see how much mistakes you did, small, I mean small mistake, right?
Yes.
So you don't know the
Yes.
dose is wrong, you don't know when to monitor,
Yes.
when to escalate the dose after 15-30 minutes, what are the red flag signs, what are the monitoring you need to do, right? What you need to do in bolus, what you need to do in doing the maintenance. This is what they practically ask you in the exam, right? They won't ask you very high-fi things. So what is like, tell me the dose of hydromorphone, and that fine, it is little advanced, right? This is a job of hematologist or pain consultant. What is being a general practitioner in Oman in the clinic, right? When the sickle patients comes to you with the crisis, how you manage, is that clear? Yes or no?
Yes, sir.
Yes, sir.
Right? And these all are the basic points and tips and tricks, right? So that is why I compiled all the data, maximum data, right, which brings more clarity to you. So this, we are not stopping here, we are jumping to the next topic for the next time. But your homework is to see once again, open up complete chapter of sickle cell disease. So we discuss lots of point with all pain crisis complication. This 16 questions, I think what I have shown you in the last is almost, I think,
Okay.
complete the session. If you remember this, right, lots of things and clarity you will get it, isn't it? Right? So
Yes, sir.
Yes,
we
sir.
almost touch all the parts of the sickle cell. And still, if you have any questions, I would like to answer you very happily. So don't hesitate to ask me the questions. Probably you put it. I'm also a little bit busy hemato-oncologist practicing. That is why my lectures are a bit late in the night or morning early, because of practice. But I would be very much a responsible guy. So you feel free to keep in touch with me, direct message or in the group. That's fine. So everybody will learn. But now onwards, both of your job is to once again go and read the sickle cell. This is one of the
Okay,
most
sir.
high yield topic for the Oman Viva. We don't want to miss anything from this sickle, because what happens when they ask
Yes, sir.
first question sickle, and believe me, if you ask this question, answer these questions well, you are in first question, they make up their mind, you are pass. Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. So that's all from my side. Thank you very much, both of you, for joining. So I'll keep you updated in the group. Just keep a watch on the group. So probably I'm planning to do it on Saturday or Sunday. Just keep in touch with me. Still, I would
Sure.
like to take one more class on the anemia where we cover the leukemia part. Anemia is a
Okay.
very
Okay, sir.
common. So iron deficiency, global problem. Thalassemia or sickle cell is a global problem, right? Like leukemia is less common, but it's important point. So little bit read about the leukemias. Get ready with the questions of leukemia. We'll discuss
Sure, sir.
in detail of leukemia. I'll solve all your queries with leukemias, right? Because primary my expertise is in leukemia and all blood disorders. So I'll try my level best to make clarify your concepts well.
Okay, sir. Thank you so
Anything
much.
else?
Okay, sir. Thank you, sir. Nothing.
Any
Thank you,
question?
sir. Thank you for everything.
Thank you very much. So we'll
Yeah.
keep in touch. God bless you and good night. See you tomorrow. Thank you.
Thank you, sir. Thank
Thank
you.
you.
Finish your homework.